Hi, this is Lisa Almedina McQuaid and Ahmed Nahari's journal article critique presentation for Kinesiology 724. Thanks for joining us. Our journal came from the Journal of Gerontology, Medical Sciences, and the title of the article was "What is the Impact of Physical Activity and Physical Function on the Development of Multimorbidity in Older Adults over Time?" as a population-based cohort study. This study was done in 2017. So initially, let's figure out what multimorbidity is defined as. Multimorbidity is defined as a co-occurrence of two or more chronic medical conditions. It's associated with poor function and future function. Also, grip strength and gait speed are linked to physical function. The physical activity connection comes from previous findings where the odds of multimorbidity were lower in physically active individuals. The aims of this study: first, to assess the impact of physical activity and the function of the development of multimorbidity over a 2-year period in an older population without multimorbidity at baseline. So these individuals had one issue at baseline or none. The second aim was to assess the impact of physical activity and the function on worsening of multimorbidity over a 2-year period in an older adult with an established multimorbidity at baseline. So these individuals had 2 or more conditions. The methods used include a design of a secondary analysis of a longitudinal cohort study, and the database came from the Irish Longitudinal Study on Aging, and we'll have a website link where you'll be able to go and see information from the Trinity College in Ireland. Inclusion criteria included 30 chronic conditions, then consolidated into 16 chronic conditions or groups of conditions. Example, cardiac conditions, eye disease, and cognitive impairment. There are 2 waves of this assessment, the first wave and the second wave. For measures of morbidity, so we had 2 groups: no multimorbidity, 0 or 1 condition, and then the multimorbidity, 2 or more conditions. So the individuals, the subjects, were divided into these 2 groups based on their conditions. The measures of physical activity and function included the International Physical Activity Questionnaire, IPAC, the short version, and we'll have a link to this as well, a PDF that shows you what this is, and then the grip strength and gait speed. The co-founders to the study included age and sex, education level, body mass index, smoking, and socioeconomic status. Statistical analysis included the modified Poisson regression analysis with a robust error variance, a logistic regression model. The p-value was set at 0.05 at a 95% confidence interval. Software was a stat of version 13. So again, just to take a look at the subject base. In terms of results, started out with a sample of 8,175 individuals. 148 were lost in the first wave. Okay, and we'll look at that. 173 were lost in the follow-up on the second wave. So the loss, part of the loss comes from after testing IPAC, the grip strength and gait speed. People got bumped out, and so the sample size, final sample size, was 4,823. It's like a little less than half from what we started with. So the subject base in the no multimorbidity included 2,235 individuals. The multimorbidity, remember these individuals had 2 or more conditions, had 2,588 subjects. In the second wave, the 2-year follow-up, there was a 30.6% increase in developed morbidity. So an N of 638, and divide that by the subject base. Remember, we lost 173 in this follow-up. And then the multimorbidity, 2 or more conditions, and the number of subjects was 1,005, and the increase was 41.6%. 41.6%. The characteristics of the subjects, there's no significant gender differences. There was a majority of the group that were non-smokers, overweight, or obese. 41.3% had high cholesterol. 33.6% had high blood pressure. 26.3% had arthritis. 6.1 to 16.7 had heart condition, diabetes, respiratory disease, eye disease, or osteoporosis. And the development of morbidity group, and the age 50 to 59, 60 to 69, and comparing them, the relative risk factor was 1.3, remember that's a 95% confidence interval. Greater than 70 years, the relative risk was 1.35. Obesity, the relative risk was 1.26. Gait speed, relative risk, 0.67. But there was no evidence for the International Physical Activity Question. Worsening of multimorbidity. Comparatively here, 50 to 59 years, 60 to 69 years, the relative risk was 1.2. Greater than 70 years, the relative risk was 1.18. Access to government funding primary health care, relative risk was 1.2. Grip strength, relative risk was 0.99. So for every kilogram of increase, the worsening decreased. So the relative risk decreased. Gait speed, relative risk was 0.61. For each meter per second increase, the worsening decreased. There were no significant association with the IPAC. Complex multimorbidity, from baseline developing new conditions, 43.1% developed new conditions. Gait speed relative risk was 0.59. Comparing age 50 to 59, 60 to 69, the relative was 1.18. Greater than 70 years, 1.2 was the relative risk. Gait speed, no significant association here. The author's interpretations included 3 areas. Gait speed, grip strength, and increasing age were significantly associated with the development of multimorbidity and the worsening of existing multimorbidity, with evidence of a dose-response relationship. Individuals with obesity were more likely to develop multimorbidity compared to normal weight individuals, though obesity was not associated with the worsening of multimorbidity. Finally, results regarding socioeconomic status were mixed. And the authors stated that the results regarding socioeconomic status being mixed might be related to the higher prevalence of socioeconomic deprivation in those with established multimorbidity at the baseline. And these results can relate maybe to the measure used, as it does not identify with the most socioeconomically deprived groups within the cohort, as income thresholds for access to government-funded health care increased with age. So government health care and ability to seek care could be a factor involved in this. Our interpretation is that the development of worsening multimorbidity over time is a natural process of the body. Physical activity is the best medicine to harmonize the body's systems. As one system becomes diseased, it's bound to affect the other systems. So the author's findings were to be expected. We're wondering how you might better assess physical activity. We'll be looking at 4 questions about this particular article in our discussion board. And one, we're going to be looking at the database, the Irish Longitudinal Study on Aging database. And we've got two links here to kind of help enrich your response. So how generalizable might these findings be, and what suggestions do you have for improving the subject base? Again, you might go to these web links to enrich your response. The second question is the author selected the following measures for wellness: grip strength, gait speed, the IPAC from Tilda findings to do their analysis. So looking specifically at IPAC for this demographic, which measures 5 domains: job-related physical activity, transportation physical activity, housework, house maintenance, and the caring for family, and then recreation, sport, and leisure time physical activity, and time spent sitting. So there's the link to actually see the short version of the IPAC. How valid are the other measures that were used as well, and how might these measures have affected the outcomes of the study, and should these measures be improved? If so, how? If not, why? One of the strengths of this program is that we all come from various backgrounds and bring a wealth of information from different perspectives. How do you see yourself using the author's conclusions? Are they helpful? What you would have expected? Why or why not? And how might we build on the author's findings for future research? So we'll be going to the discussion board. Ahmed and I, we're going to be in separate discussion boards, and we look forward to kind of leading this discussion and leading you online. Thank you for listening.